Hi everyone. So this is a presentation related to Chapter 1. Chapter 1 is entitled Healthcare Reimbursement and Revenue Cycle Management. As I noted in the Lesson 1 overview, Revenue Cycle Management, or RCM, is a term that you should become familiar with as you move through HIM. It is focusing in on the management of all elements that have to do with the revenue cycle, which for the health information management professional typically revolves around, doesn't necessarily only include, but it does revolve around medical coding function and those offshoots of that functionality, which include billing and understanding the payer system we have here in the United States. At the beginning of the textbook and here on the slides, you do have the learning objectives. I think one of the things you have to kind of pay attention to as you move through reading and studying Chapter 1 is the idea that the United States healthcare system is unique, but it is not haphazard. Sometimes people have a tendency to think of it as kind of very complex, which it is, but also that it kind of grew up the way it was, but it has a historical component to it. There is a history of why we are with the healthcare system we have right now. And so this chapter gives you some background information and talks about the business model that the US uses and also compares that with other countries or other major healthcare reimbursement models that are currently or historically present. And this is just talking about your introduction to healthcare reimbursement. As an HIM professional, we are typically not having a lot of patient interaction. But one area where we do have patient interaction is when we're talking about the reimbursement piece, helping people understand their co-payments, whether it's inpatient, outpatient, etc., or helping people when they're dealing with self-pay and having to navigate that from a financial standpoint. One growing area that we perhaps will delve into as we move later in this class is the idea of a patient advocacy, and that would definitely be an area of financial advocacy, consumer engagement. When we talk about specifically patients who have no healthcare coverage and need to have an encounter with a healthcare facility, they need to have some type of major surgery, or patients who are underinsured. They perhaps have been able to purchase some type of insurance through the Affordable Care Act, for example, but the type of insurance they are able to purchase is not meeting their needs when they need a healthcare encounter. This chapter also provides you some terminology. They'll give you the definition of reimbursement. They also tell you what a revenue cycle is, and then they give you the definition of revenue cycle management. And as you are going through, you definitely want to make sure that you are taking notes for yourself and perhaps keeping your textbook for later reference as you begin to navigate the last courses that you need before you achieve your degree. And you also should have these books and these resources accessible to you as you begin your career as a health information professional. Three specific models of healthcare delivery are talked about. The first one is the social insurance model, also known as the Bismarck model. You should know both of these terms. These are synonyms. Then we have the National Health Insurance Model, or the Beveridge model, and then we have the private health insurance model. In your textbook, they also give you a little bit more detail on countries that are currently under these different two models, the Bismarck and the Beveridge model, and that should be something you pay attention to, so that when you are talking about healthcare, especially on a global landscape, you are able to make comparisons and give specifics, and it's not to say, well, the U.S. healthcare system is different than other countries. Well, what other countries are you speaking of? And so, for example, the U.S. healthcare system is very different from the U.K. system. Also from Sweden, they have what we call national healthcare, and in those countries, typically the government is the payer, and the citizens of those countries have national healthcare coverage. The government owns all of the healthcare facilities. The government is the employer of the physicians who work, the physicians and the nurses and the staff members. And one element of that typically is that the taxes in those countries, the individual income taxes, is much higher because that's the revenue source of how the government is able to pay for covering all of their citizens with health care. In the United States, we don't have that model. We have Medicare, but Medicare doesn't cover all citizens. And so we have a more complex model, and there is some great information in more detail in the textbook on our healthcare delivery system here in the United States. They also give you the U.S. healthcare business model, and this particular component of Chapter 1 is one you want to pay attention to because you will be doing an assignment based on this particular concept. As you are working on the assignment, you certainly are able to refer back to the textbook and to your notes. And so that is the idea, that you are taking that time to use and apply and make sure you delve into the depth that you need to delve into a particular concept, in this case, healthcare business model, when you're working on the assignment. So please use your textbook and any other materials. If you need to do an internet search, you need to do some research, you certainly can do that as you are working on course assignments. This particular slide is comparing the healthcare business model to a grocery store business model, looking at the supplier, the transaction component, and the consumer. In the last few years, in the United States specifically, in some areas you will start to hear, or you started to hear about patients being referred to as consumers versus patients. And so typically when you hear that, it's typically coming from an executive or someone who doesn't work in direct patient care, because they're looking at it from a financial or a reimbursement perspective. More terms that you need to understand: health insurance, policyholder, and beneficiary are just some of those terms. Information on health insurance premiums, and then it delves into the historical perspective, which again is very important so that you understand how we got to where we are in the United States currently. And one of the major kind of catalyst moments for our healthcare system, specifically because it resulted in Medicare coming into existence, was the ending of World War II. The other component was the idea before that, actually, but historically, this idea that someone decided or thought, it would be a really good idea to cover or give health insurance to our teachers. And that's what was the catalyst behind Blue Cross Blue Shield. Historically, before, and I believe they might talk about it, I know they've talked about it in some of your other textbooks, but people were covered by their employer, but it wasn't as organized. And when we were a more industrial country, people were working in plants and manufacturing things, and people were getting injured if they were not taken care of. Their lives were pretty much devastated because if they suffered a major injury and were no longer able to work, they were destitute. And so that was one catalyst for starting to give people health insurance coverage or giving them some type of avenue. It first started out with having a physician, being a physician who worked for the plant, and he or she, or most likely he, was responsible for taking care of the employees and taking, like an on-site clinic type environment. And that kind of then grew into the Kaiser model, which we still have today. And then we also have, as noted here, the beginnings of Blue Cross Blue Shield. In the United States, the largest group of people, there's two sort of pockets, I guess, of payers. There's the employer payers, where people who are working and have full-time benefits and are getting their insurance through their employer. Most of that now is the employer pays some portion of their healthcare coverage, and the employee is also paying a portion of it. The other larger pocket of healthcare coverage in terms of a payer system in the United States is Medicare. And so those are the two angles. But I think the largest majority of people in the United States have what we call employer-sponsored health insurance coverage. This is talking about the third-party payment system. Patient or persons receiving services is the first party, which we typically refer to as the patient. We could also call them the client. The second party is typically the person who is rendering that service, which would be the provider. That could be the physician, that could be the hospital, that could be the clinic. The third party is an uninvolved party that is paying for the healthcare coverage, which is typically called an insurer or a payer. And that could be Blue Cross Blue Shield, could be Medicare, could be Medicaid, etc. Revenue cycle management is, again, a more management-focused framework of looking at all of these elements that have to do with healthcare finance. There is certain components of revenue cycle management, as noted here. Promoting of collaboration, emphasizing education, and taking a proactive stance on reimbursement issues. One of the major drivers of those reimbursement legislation, of course, would be CMS and the federal government, because they are determining the rules for their Medicare recipients and the provider relationship that comes with that. And we'll talk about provider relationship in this class. But the idea of emphasis on education, why is that important? Our system is complex here in the United States, and we have a variety of healthcare type facilities, providers. We have different types of providers, meaning different types of physicians. We have specialty physicians. We have the HMO component, where you have that gatekeeper component, where the physician is, the personal care physician. The patient has to go see the PCP before they can go see a dermatologist or something like that. And the rules change. And the rules are changing rapidly in the last 16 months, specifically around the idea of telehealth and telemedicine or e-health. This is telehealth, telemedicine, e-health are not new concepts. They have been here for a while. But the use of them in the last 16 months has changed the landscape of healthcare reimbursement, because one component was that before the pandemic, the restrictions on Medicare, specifically paying a provider for telehealth, was very, very severe. So there were a lot of rules, so to speak, where providers, even if they wanted to use telehealth, they really weren't going to use it because they weren't going to get paid. Medicare was not going to reimburse them for telehealth services. But because of the pandemic, Medicare has had to make some changes. So this idea of education is important. In one of your other classes, we'll talk about evaluation and management codes. There was a major change in evaluation and management codes, and in that particular case, those codes and the standards required of how you assign them is determined by the American Medical Association. So this emphasis on education is important because the reimbursement component with all the various players, the large insurance companies and the federal government being two of the major ones, determine certain elements. And when they change their rules or they clarify something or they decide to update something, that has to be communicated out. And it could have obviously far-reaching impacts because of the amount of facilities, the amount of providers that we have in the United States. Another key component you want to make sure you have a good understanding of is this idea of revenue integrity. As an HIM professional, ethics is very important, and we want to, if you are in that role of a revenue cycle manager, or you're in the role of a HIM finance director, or you're having some influence over the finance piece and the medical coding piece, you want to make sure that things are being done in compliance. And we'll talk more about the legal ramifications, but you want to make sure that you are submitting correct per your current understanding and knowledge of the requirements of the payer, and you're not changing your documentation with the idea of trying to increase reimbursement for the sake of increasing reimbursement. Integrated revenue cycle. This is a concept when it happens quite often in healthcare because hospitals or systems buy up other components. They buy physicians' offices or they buy other hospitals, and so they have to integrate their revenue cycle. There's benefits to doing that and also difficulties as noted here. The components of the revenue cycle, which we will talk about throughout this class, will do the front end, which includes the process of patient engagement, which is when you walk up to the doctors, you walk in the office, you walk up, you sign in, that whole front end process. Then we have the middle component and of course the back end, which is what happens behind the scenes after the patient has had their healthcare encounter, whether that's in the office, whether that's in the outpatient arena, or whether that's an inpatient hospital stay. Patient perspective is looking at the detail of a revenue cycle from a patient's viewpoint, starting with your scheduling. Typically, if it's a non-emergency type situation, patient scheduling an appointment. Patient is admitted if there's any copayment that needs to be paid. If the patient has insurance, there could be. Now, the good thing about telehealth, there's no copays for telehealth at the moment. Treatment is provided, and the patient is hopefully discharged. That could be discharged from the office visit, or discharged from the outpatient suite, or discharged from the hospital, etc. This is the revenue cycle from the facility or the provider perspective. And this is looking at typically, something that the patient needs to, like an outpatient procedure or a inpatient stay. Typically, when a patient is being seen in an office for an office visit, whether it's a checkup or maybe they have a sinus headache or maybe they have a rash on their hand, a patient typically doesn't have to have that type of encounter pre-authorized. So this is definitely an inpatient type of revenue cycle. But the idea is typically the patient is scheduled and pre-authorized, the patient is admitted, information is verified, and again, this is assuming this is a non-emergency situation. Services are delivered, charges are rendered while the patient is being in the hospital, they have something called a charge master. So every time they give you, medication, they credit it to your account. So they're keeping kind of a running tab while you're in the hospital. Um, and then the patient would be discharged. And typically we do what we call retrospective coding, and that is after discharge, the coders assign codes, the claim is produced, and typically there's going to be some type of auditing or review process called scrubbing. In order to try to make the claim as clean as possible, they may go do a second review of the patient's, because one of the major reasons why claims are denied is a demographic error. They have either the patient's wrong birth date, they have one digit wrong in their health insurance number, or something that's somewhat minor in a sense. And so they probably should, best practice would be to audit the claim and make sure that all the demographic information is correct. The patient's name is spelled correctly, their health insurance number is correct, their date of birth is correct. And currently in the United States, claims are typically submitted electronically. And so that process would be a transmittal process to the payer directly from the facility, or from the billing component of the facility. And then there's a tracking system of how long the payments have been out, how long the claims have been out there, and what is the were they denied? Was there a question? Did the insurer ask for some more information for certain situations? They may ask for copies of the medical records depending on what was coded. There's some nuances to that, but for example, if the it's a new procedure, maybe it's something that's somewhat viewed as experimental. Maybe they should have gotten it pre-authorized and they didn't. So there could be a lot of reasons why the insurance company is asking for further clarification, more information before they are going to pay the claim or issue the denial. And then hopefully the claim is paid. They send what's called a remittance advice. And then if there are any cost sharing components, if the patient is responsible, if it's a Medicare patient, Medicare pays 80% of their fee schedule, the patient is responsible for 20%. Now, if the patient has a secondary insurance, which many Medicare patients do, then the hospital hopefully has that information and they send off the information to the secondary insurance. But if the patient doesn't have secondary insurance, or if the patient's on an 80-20 plan, there's 80-20 plans for private insurance. For Kaiser, for example, has an 80-20 plan. And so as a patient, if you're a Kaiser patient and you have the 80-20 plan, then you would be responsible for 20%, and they would be billing you for that 20% after they have gotten the 80% of the fee schedule, which is an important component, which we'll talk about more in this class. If, for example, if the hospital billed, patient had their appendix removed and the hospital billed $5,000 for that room and board and for the use of the OR, etc. But Kaiser said, okay, that's great, we'll pay for it, but we're only going to pay you, we only think this is valued at $3,000. And so that's the starting point, is $3,000, not $5,000. So if the patient had an 80-20 Kaiser plan, the patient would be responsible for 20% of $3,000, not 20% of $5,000. So that's where that remittance advice is important, because the remittance advice is basically telling the facility, this is the value that we as the payer give you back for what you billed us. We got your bill had this amount on it, this is how much we think it really is worth, the services that you provided, and here's what we're paying based on the plan that the insurer has with us. And if there is any cost sharing component, then that would be the last piece of this puzzle. At the end of each of these chapters, you have sort of a real world kind of scenario. They will be using, your textbook authors will be using patients, the same patient, over multiple chapters. And as warranted, they will switch patients when needed. The first patient is Malachi. Malachi is a 68-year-old male who is a Medicare recipient. The second patient at the end of chapter 1 is Olivia. Olivia is a 30-year-old female who has a commercial payer that she has gotten through her employer. This particular case study, if you want to call it that, or illustration in chapter 1 is identifying kind of the concepts of the relationship between the patients, the two patients, Malachi and Olivia. We have Dr. Lewis, and we also have Dr. King. So again, earlier they talked about the first party is the patient. So we have Olivia going to see Dr. King, and the payment is coming from her payer, which is SuperPayer. Then we have Malachi, who's going to see Dr. Lewis, and his payment is coming from Medicare, which would be the third party. And this model is identifying the patient connection between the patient, the payer, the patient, the provider, and the payer. And that brings us to the end of chapter 1. Again, as you are going through chapter 1, please make sure you're taking notes. You certainly can download these PowerPoint slides for your personal use. You also should take the time to go through and answer all of the Check Your Understanding questions, and then look at the provided answers to those Check Your Understanding at the end of chapter 1. And the last thing you should be doing before you tackle the assignment, which is a graded and submitted element, is looking at the chapter 1 review. And for the purposes of chapter 1, you have 10 questions, and it would be best to try to jot your answers down. You don't have to you're not submitting anything, so you certainly can take little notes and just kind of say, oh, if I was to write this out, these are what I would talk about. And then look at the provided answer key for the chapter 1 review quiz. If you don't understand, once you have looked at the answers to the review quiz, that's when you should be asking questions, posting to the discussion board, or emailing me directly at my hawaii.edu email or through La Lima email. The answer key is provided to you, but if you just read the answers and you haven't tried to tackle those questions, that is not the most effective way to ensure that you understood the content of chapter 1. And the content of chapter 1 is a foundation. You won't have a great house if you don't have a great foundation. So it's important that you pay attention to how you are studying and reviewing the information in these early chapters, so that when we move through this semester, you will have that great foundation to help you understand more complex concepts related to revenue cycle management and healthcare reimbursement.